they just get blatantly told it's just in your head, please get out. And what that does is that drives a sense of hopelessness. It drives then helplessness, and that combination drives suicidal ideation.
What would be your words for them? And I know that's a very challenging question.
Oh, easy.
Perfect. That wasn't challenging at all.
It's easy. And the amount of times I've said that to patients is innumerable. And the amount of time they then tear up.
Today on Pain Coach, we're joined by Dr. Dan Bates, a sports and exercise medicine specialist, director of the Back, Neck and Joint Clinic in Melbourne, and former head doctor for both Melbourne and North Melbourne AFL teams. Dan has an empathetic way of helping people take back what pain has stolen from them.
This podcast is for educational purposes only. The views expressed in this podcast do not constitute medical advice and are general in nature. You should obtain specific advice from a qualified health professional before acting on any of the information within this podcast. Dan, so you're a sports and exercise physician and you found yourself in this realm of working with people with chronic pain. How did you get there?
Look, there's a number of reasons for that. I think that the first reason, if you look at just at the demographics of chronic pain, so most chronic pain is musculoskeletal. So the majority of chronic pain is, so if you look at the first 90% of chronic pain is actually lower back. The next 8% is neuropathic. And the last 2% is then everything else. And so just by the nature of my training, in Australia, the doctors that generally look after non-surgical musculoskeletal pain are sports physicians. And as a result, you end up just seeing tons of musculoskeletal pain. And once you actually get booked out a couple of weeks ahead, the people who can wait have got chronic pain. So all of a sudden you go from looking after a bunch of kids that, do their ACLs or, blow an ankle on the weekend to looking after their mums and dads and their grandparents who have got longer term problems. And you need to come up with some different solutions. Like you need, it's not the same management strategies. And I've been very lucky over the years that people just, they trust me enough that they come back and they go, that didn't work. What's next? And that's just led me down the pathway where I've ended up here at, looking after lots of people with chronic pain. Like my daughter says, Dad looks after, if you can move it and it hurts, Dad looks after it. So, do I do abdo pain? No, I don't do abdo pain.
She's nailed it. That's a great summary.
My 10-year-old's marketing strategy. Go for it.
Yeah, you should put that on your website for sure.
You know what? I think I have.
Awesome. That's great. You should put her name there. She needs some.
Give her some kudos.
Yeah, that's it. Awesome.
So that's the thing. And I think interestingly, like this for me really started in osteoarthritis. And so, within the world of sports medicine, you see lots of joint related pain. And so started creating an approach to how you manage osteoarthritis non-surgically. That then generated an algorithm, how I approached them. I then joined Metro Pain Group, and I then through time started applying that algorithm to back pain and then neck pain, and I found it worked. And so now here we are doing arms, legs and backs.
Yeah, awesome. We'll talk about your algorithmic way of going about things at some stage, because I'd love to sort of pick your brains about that. But the question that I want to ask, because I know you have a podcast that says it's not in your head, is the title of the podcast. And I'd just love to hear your thoughts. So say I'm someone that I've been told that pain is in my head. What would you say to me?
Yeah. Okay. So I don't actually think people get told it's in their head most of the time. Okay. So what happens is the patient hears that they've been told it's in their head. and it's never deliberate. It's just the way it's perceived. So phrases like "it's a false alarm," it's a misinterpretation of a signal. What ends up happening is that those get perceived as, so you're telling me it's in my head. Now, you're not being told it's in your head. It's being told that it's a false alarm, it's a misinterpretation, but that is how it's perceived. And so, in a small number of patients, and this is really where the issue comes. And so, where the podcast title came from was this very regular, and it still happens, where my patients will go see somebody else and they get told it's in their head, or they heard it's in their head, or like they just get blatantly told it's just in your head, please get out. And what that does is that drives a sense of hopelessness. It drives then helplessness, and that combination drives suicidal ideation. And so that I was just got to the point where I'm just sick of my patients coming back like in tears and suicidal because of the way something's been said to them. And so there is certainly a subgroup of patients out there that if you take them through the process of recognizing that, yes, your brain interprets a set of signals that then become pain, they are then able to change that and they get a substantial benefit out of it. No doubts about it. However, I think that there's also a subgroup of patients that go away, hear that as it's in my head, and become suicidal. And I think the risk benefit ratio within that explanation doesn't lay out for me. And so we need to look for different words for how to explain pain to patients.
Yeah.
And I think that it's just those words that are the issue. And you know what? We're trying to like promote a podcast. It's not in your head for chronic pain patients. They respond to that. So, that's part of it as well.
Yeah, for sure. Yeah, I think really at the core of this is you want people to feel validated, and people should feel validated. So it's a worthy thing. And I think I wonder whether there's, because I think what people hear, and I'm coming from a camp of, I've gone through Lorimer's training and those kind of things. So people kind of they know that I've had that teaching, and Loz himself has come out sort of saying, hey, there's some certain ways that we could have done things better, and this was misinterpreted, and I think his intention and his heart is in a good place. But I think at the core of it is this like needing of validation, because if people say it's your head has a role to play in it, and therefore are you telling me I'm fabricating it, I'm making it up, I'm to blame, or it's not actually real, then that is extremely problematic, because like you said, that would lead to feelings of helplessness and suicidal ideation. But I also see the group of people that have been to specialists, like yourself and orthopedic specialists and a number of different specialists, and they've heard this, there's nothing we can do, time and time again, or there's no reason we can find for your symptoms. What do you, because in those people, I feel like they also experience helplessness. And look, this is a smaller demographic.
I know they absolutely do.
But they absolutely do. They experience helplessness, despair, and suicidal ideation. And I think your nervous system and your brain has something to do with this. Actually, gives them hope that despite the fact that they can't find something wrong with me from a bodily structural point of view, there is something I can do. So
yeah, sorry, I think there's a ton of stuff in that we can tease about. Okay, so firstly, the statement, and really what it comes down to, there's nothing on your scan. Okay, that's really what the words is, or I can't There's nothing on the scan. I think the thing you have to focus on there is that it's just that our technology is limited. Just because you can't see something on a scan doesn't mean there's not something wrong. It just means you can't see it on the scan. I think, if you go back to the first DSM, which is the diagnostic manual for, I can't even remember what the titles. The first DSM-1 listed ulcerative colitis and peptic ulcers as part of the psychogenic. What is it? It's psychogenic. It's not conversion disorders, but it basically it lists them as a psychogenic disorder. At that point in time, we did not have, that's 1952, we did not have the diagnostic capability to be able to recognize that peptic ulcers come from a infection called H. pylori and ulcerative colitis is an autoimmune disorder. And so what would we do? We said it's in your head, it's psychogenic.
Yeah.
And so whenever we as the medical fraternity, as a group, throughout all of history, when we don't know, we always blame the patient. You're just crazy. Hysteria, you know what the first part of hyst is? Like hysterectomy, it refers to the uterus. And so, back in the day, Hippocrates blamed the wandering uterus for all the ailments that, they weren't able to explain. And so we've seen, devils, witches, demons, you name it, Briquette syndrome. That was probably the first real attempt of getting closer to, what's an underlying disorder. And we just again and again and again, when we hit our diagnostic limits, we blame the patients. Now, those diagnostic limits may be our own personal knowledge base. It might be our own personal expertise. It might be the limits of technology. It might be the limits of what the pathology group will do. Like, I know that I've got a bunch of patients that have got truckloads of inflammatory stuff going on that we just can't measure. They got normal CRPs, but we don't measure IL-6. We don't measure IL-1. We don't measure TNF alpha. And so we just can't identify it. And so I think that the better way to use words than we're unable to find the cause. That doesn't mean there's not a cause. It just means I can't find it. And I think that's when you lean into, these are the ways, these are some strategies that you can then cope better with your pain. You can down regulate the amplification that you get when you worry about it more, when you focus on it more, when you catastrophize about your pain. You know what? Pain causes depression and anxiety. You know what? Depression and anxiety makes it worse. Okay, we can't find the cause. Let's fix the stuff that is amplifying the pain. And that's where I think, a lot of the techniques from, Noi Group, all Lorimer's stuff become really, really powerful. But it has to be balanced against, the patient hearing, this is in my head.
Yeah.
And I sit at that. I think I wrote something recently about why do we think we're always right? And the reason why we think we're always right is because you only see your successes and everybody else's failures.
Yeah.
And so, and because of the nature of that, we gain increasing confidence in what I do or you do as a clinician, because everyone who comes back is better. And the ones that don't get better, they just don't come back. But they go and see everyone else and they go, oh, that didn't work. Physio didn't work. Physio made me worse. And that injection didn't work. And okay, but that's just because, that's the nature of human beings. You don't go back if something's failed.
Yeah. Yeah, it's undoubtedly complex. And I think the problem is that patients don't want complexity. They want advice, they want actions, they want things that they can do that are within their control. I want to, so let me just, because you make a really good point, and that's why I was like, hey, I want to get you on the podcast, because when we were conversing on LinkedIn and you sort of I basically said, you were basically saying the cause is always the structures, always the body. And I sort of push back in terms of going, well, I agree with you in 80% of cases, but what about those cases where they can't find anything? And that was your answer. And I think it was a really good answer.
Yeah.
Because the reality is there are things that we don't know. And what we didn't know 50 years ago, we now know, and we're now discovering. So I think that's awesome. But do you think that there'll come a day where, so with the rise of imaging modalities and all of these things, they're finding lots and lots of things, right? You know, everyone, 70% of the population say have a labral tear, and they may be asymptomatic.
Mm-hmm.
What do we do with these? So if I understand your thinking correctly, you're saying that once we have these advancements and we're able to see things better, we will find out what are the causes of some of these fringe or these less common, what we call nociplastic type pains. We'll find a structural cause for them one day. Is that correct, or is that misinterpreting you?
Yeah. Oh no. I think that if you so you get into you get a really, if you look at pain like that, I think the nociplastic thing really is interesting in the way they've sort of built its definition. You know, I think if you look at pain, you get peripheral sensitization. So you got an inflammatory soup around a set of peripheral nerves. You get upregulation of receptors out there. You get increased sensitivity to those receptors, and they fire more regularly. They then come to the dorsal root ganglion. Dorsal root ganglion, you get upregulation of receptors and cytokine release in that area as well. You get polarization of microglia and astrocytes, so they become pro-inflammatory, and so you're getting upregulation of and sensitization at a DRG level.
Yeah,
that is then taking place at a spinal cord level in the dorsal horn. It's then undoubtedly taking place in the brain at amygdala, blah blah blah. Everything that is involved is experiencing this persistent upregulation of both. You're basically getting polarization of microglia from type 2 microglia, which are anti-inflammatory cells, to type 1, which are pro-inflammatory. And then you're getting what's known as long-term potentiation. So the easiest way to think about long-term potentiation is it's just memory. It's an easier way for those nerves to fire so that they use less energy. And so you're getting that combined effect. Now that's taking place throughout the entire nervous system. And then we've come up with this definition of nociplastic pain, and all of a sudden we can't find the cause. We blame that it's all central, but have we lost that peripheral sensitization? Have you lost the sensitization at a DRG level? Have you lost it at a dorsal horn level? Is it like, I don't buy that. I just don't buy that it's just a central process. I also, I don't know, we're trailing off we're into nociplastic stuff. I think about pain not in two concepts. I think about it as what's the cause, which might be a body part causing nociceptive pain, or it could be a nerve causing neuropathic pain. Okay.
Yeah.
I then see that there's a bunch of amplifiers. All right.
Yeah.
And those amplifiers can be, metabolic, they can be emotional, they can be social, they can be disease processes. And I think if you look at, the central sensitization disorders, so the central sensitization disorders are essentially chronic fatigue syndrome, temporal mandibular joint pain, fibromyalgia, irritable bowel syndrome, POTS parts of POTS probably falls into that group. They're all associated with, a number of the same disease processes. So what they're associated in, I always say is 10, but I think there's about 8. The first thing they're associated is persistent nociceptive drive that it's either undiagnosed or untreated. Okay, whether you can't diagnose it or you just can't treat it, whatever. There's something there. The next thing that they're all associated with is inflammatory disorders. Okay, so they're associated with rheumatoid arthritis, osteoarthritis, Sjogren's disease, SLE, blah 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 blah. You pick them, like they're all associated with them. The next set of things that's associated is endocrine disorders, so hypothyroidism, diabetes, particularly in this and pre-diabetic states, so insulin resistance or just hyperinsulinemia. You then also get, and then celiac disease fits into that bucket of regularity as well. Pre-existing depression, anxiety, then hypermobility, obesity. And then the last thing in that is then a subset of metabolic abnormalities that you can then go and test for. And which I do, and I do a range of different bloods that you go test for, and you're trying to look for what metabolic abnormalities are there that you can treat that are then known to be associated with amplification in the nervous system.
Yeah.
And so that doesn't take out, and so and I basically work through a process where what I'm trying to do is I'm trying to go, okay, you're really sensitized. What's driving the sensitization? Not you're sensitized, please get out, which is kind of the main diagnosis of central sensitization. But you're sensitized, there is an underlying driver to this. Can we identify what it is? And that's where a lot of my thinking has gone. Like, it's taken a long time to get to a point where you can go, all right, what's driving this? And we know that central sensitization, which is an amplification of, I see central sensitization as nervous system dysfunction.
Yeah.
And we know that it's dominantly a neuroinflammatory process. And so the question is, what drives the neuroinflammation?
Yeah. Yeah. Great question. And so, yeah, I'm trying to work out which way to go here. So if I summarize, there's the stuff that happens in the body, in the part, say, and that's what you were talking about, inflammatory soup that kind of amplifies or sends these signals. These signals are then amplified at the spinal cord level. They may also be amplified in the brain, at the brain level, and then the output
nerve root, spinal cord, brain. Yes.
Yeah. I'm just trying to simplify it for, say, the average person. So you got your body part that's amplifying this signal, sending this signal, and the inflammation around there is amplifying it. Then at the spinal cord level, it's being amplified again, and then at the brain, it can also be amplified, or even we're saying amplified in the bad sense, but it could also be turned down. That dial could be turned down at each of those levels. Yeah.
Yeah, so that's sort of how I will be thinking about, how am I going to treat this?
Yeah.
Where like I'm trying to identify where's the amplification coming from. So is it all peripheral? Is it all central?
Yeah.
Or is it a mix of both? And so you'll find that there'll be, one of the main central drivers of sensitization that is, long way upstream is someone who's experienced sexual abuse. Or another one that's really big is, that seems to be very, very strong, is assault at work. Believe it or not, being assaulted at work really drives central sensitization. I think it takes away a large amount of safety within that environment. But so, for patients that have had an assault at work, wow, that is real. They have a very powerful central driver that you really need to work with your psychologist, work with all your team to deal with that trauma and get on top of that.
Yeah.
I've got a set of patients that, that are the other way, that they are, they've got a great life. There's no major psychosocial pressures. They have, but they are hypersensitive to touch. There's central when I'm looking for central sensitization, I do a thing called the central sensitization inventory. It's a little score that you can just download and fill out yourself. And if their sensitization's low, but they're really touchy, it's all peripheral. So you then have to work out, okay, how do I downregulate this peripheral sensitization so I could get at the underlying, cause?
Mm-hmm. Yeah. Yeah. So from a patient perspective, I mean, I think we could talk about causes of pain way, way, way too much. Because there's so many types, right? But the amplifiers of pain, what would be, you've mentioned a few of the top ones that you see. And some of those things are out of the patient's control, and they're happening at at the spinal cord level and those kind of things. But for what's
Mm.
in the patient's control, what are the amplifiers that you find when people do X, Y, and Z strategies? They seem to do better when it's, say, centrally driven or from the brain nervous system side of things.
So you're asking what are the so your central drivers that are non-metabolic effectively, I would see as your anxiety and your depression,
Mm-hmm.
PTSD, major social stress. And so
Mm-hmm.
stress is such an interesting discussion point when you start looking at concepts around allostatic load
Mm-hmm.
and how they then, wind up your nervous system.
Yep.
Catastrophizing and self-efficacy. So I think that if the things that you want to focus on, if you go, okay, what's 100% in my control? All right. So what's 100% in your control is, firstly, you've got to take control. If I guarantee, if you want to have chronic pain forever, don't own it and blame everybody else. Like, that is a guarantee for this to last forever. Number two, I think you got to is then catastrophizing. So catastrophizing is when people catastrophize. You amplify it with the words that you're using and the way that you're thinking about it. So people that catastrophize, when I'm looking for it, how I'm picking it, I'll just ask them, what's your pain out of 10? And if they tell me it's 10, well, guess what? They're catastrophizing. Because I think I've seen 2 10s ever. Because what most people report is that they don't report the actual pain. They report how much it distresses them. I've now had 2 patients ever that say to me, Dan, my pain is 1 out of 10, but it annoys me 9 out of 10. Right. Okay. So that's a rare individual that's able to split the two. What most people do is say, my pain's 9 out of 10. What they're telling you is it just really, really annoys them. And so other ways that you can pick catastrophizing, particularly in yourself, if you're using, words like, I feel like I'm getting hit with a sledgehammer. I feel like my leg's getting cut off with a chainsaw. Now, firstly, there is some disease processes like complex regional pain syndrome that actually feel like that. So don't let me put that to the side. But it's the use of those words that then further amplify the pain. And you can change it. You can change the words that you use, and that can help get you better control over your pain. Recognize the other thing then is then recognizing and just accepting you're depressed. Honestly, if you've got chronic pain, you will have lost so many things that you love. You will have lost friends, you will have lost family, you will have lost jobs, you will have lost, the ability to do things you love to do. If that doesn't make you sad, you're not normal. And so it's okay. It's okay. Just it's okay to go, hey, it's okay for me to feel bad about this stuff, but I got to go on and sort it out. And it's the same with if it moves, if every time you move it hurts, and that makes you anxious and it makes you scared to move, well, guess what? That makes you normal. Like, and if you're not scared to move, you're not normal. But you can go on, you can manage that. That can get disproportionate, and you can do a large number of strategies to improve that fear of movement to get on top of your anxiety. So they're the sort of things like, and
Yeah.
if you recognize that, no one comes in and tells me about, their childhood. No one wants to come in and tell me about their childhood. No one comes in, or very rarely do people come in and tell me about their history of sexual abuse. But if it's there for you and it's there, just go, okay, I have to accept this. It's here. I can deal with it, and this might help my pain. And you're just taking ownership over, all the things you can take ownership over. That's what I encourage people into.
Yeah.
It's hard though. Like, and if anybody says it's easy, like, they don't have chronic pain.
Those are really practical answers, and I appreciate that. That's exactly where I wanted you to go, try to tease out some of those practical things and ways that people that are dealing with it can reduce that amplification that we've discussed. Do you?
I want to give another practical tip, okay?
Yeah.
Because this is one of the things that I encourage patients to do. Whenever I have someone who comes in that says someone's told me that it's in my head, what I just get them to do is say, okay, next time it takes place, I want you to do this. I just want you to say 2 words, want to swap, and then be silent. Because if someone, blatantly just says it's just in your head, get out. If someone uses a set of words that make you feel like it's in your head, just ask them if they want to swap. But you got to wait that moment of silence afterwards, because in that moment of silence, they step into your shoes and they go, yeah, no.
Yeah.
And you just gain that little bit of power back. So yeah, just lock that one away. Next time someone does it, just ask them if they want to swap.
Yeah, like you said, I think it's a fair point. Most clinicians, especially to be honest, if they say it like that, they, like, if the clinician says it's all in your head, they don't understand pain. Let's just be blunt.
No.
They might understand, and to be honest with you, from my experience, and this is just my experience, yours might be different. A lot of those experiences are from specialists that are very good at, and don't get me wrong, we need specialists that are very good at looking at this particular object or whatever it is, but they're so specialized, and when they don't know what to do, they go, oh, it's psychosomatic, which I hate. I hate the phrase psychosomatic. It drives me insane.
Me too. It's not real. Yeah.
And yeah, I don't know. Is that your experience?
Yeah, so that's exactly that. And so what's happening there's a couple of things happening there that I'm glad you really bring that up. So where we need to go is we are not comfortable as a profession of saying I don't know. Okay? When we are training as students, if you said I don't know, you get destroyed. Okay? And you'll be standing next to a patient's bed and you'll get asked a question. And if you say, I don't know, you are generally stripped down and, made to feel stupid. It's done in front of the patient. So you just feel terrible. So the words I don't know for a doctor are very, very hard to say. Okay. Because it's drilled into us from the start. But I think that what we need to move to do is it's okay not to know. You know what? I'm good at arms, legs, and backs. Okay. I'm not great at abdo pain. I haven't seen like chest, like internal chest pain for like ever. Am I good at do I know how to manage blood pressure? Absolutely not. Like I
Mm-hmm.
don't know. Okay. And I think that when we get to that point where you're like, you know what, I don't know what's happening for you, it should be followed up with, but this is what we'll do. Okay. You don't need to, as a set of doctors, we don't need to know everything,
Yeah.
but we do need to be able to say, I don't know, this person's, I think, the right person for you.
Yeah.
I don't
Yeah.
know. I'm sorry. I'm not the one to help you here. You need to talk to your GP again. And it's okay. But it's
Yeah.
not, the answer isn't, I don't know, you're crazy, which is
Yeah.
actually is the way, you know, which is what's being said, or I don't know, it's in your head, psychosomatic, whatever. So yeah, I think that there's a very large change in culture that we need to make to just be able to say, I don't know. And it's
Yeah.
okay not to know. But
Yeah.
you have to have a
Totally.
plan. You have to have a next step.
Yeah. Yeah. I totally agree.
The other thing that's interesting as well, that I think that you raise that issue that specialists are specialized. Okay. Like I do arms, legs, and backs. Okay, great. So the thing there is that if you're going to see a specialist, the specialist, you're not going to, like, the specialist doesn't want to sit there and go through a broad-based, multidisciplinary, unless that's their gig, unless that's their role within a specialty environment. That's not what they're there for. They're not there to see, have you done your rehab? Have you spoken to the
Yeah.
psych? Have you
Mm-hmm.
worked through these medications? They're there. You're going to see them for specialist knowledge to go, hey, I've worked through this sort of stuff. It hasn't worked.
Yeah.
What's next? And they'll be sitting there like chaping at the bit to use whatever magic tricks they've got in their back pocket. And they've all got like magic tricks in their back pocket that they want to use. But that's what you need to be you need to be going to them for. And so when you go and see a specialist, you've got to go in with that sort of attitude. Like they're not going to give you you're not going to find out, how do I do a broad-based, fix everything.
Yeah.
You're going in to go, okay, this is the problem I have that's in your wheelhouse.
Yeah.
How do I manage this problem? And
Yeah.
they're
Yeah.
great at that.
Totally.
One thing I do want to like highlight in this is like this concept around number needed to treat, and we'll do it within the around medications. And so with medications, particularly with nerve pain, we use four main medications. Everybody on the Let's Listen and probably work through them all. So the first one's amitriptyline or NDEP. The second one is duloxetine, commonly known as Cymbalta or Andipra. You've then got gabapentin, which is Neurontin, and then you've got Lyrica, which is also known as pregabalin. All right, so the whole concept of number needed to treat is the idea that I have to treat a certain number of patients to get one better. Now, within the world of neuropathic pain, that the amount better that people get is about 30 to 50%. All right. So if you've got pain that's 9 out of 10, you're taking somebody from a 9 down to a 6, or an
Mm-hmm.
8 down to a 5-ish. Okay. So to get one person better with NDEP or amitriptyline, you've got to treat 4. Now, if you're a glass half full person, that's a great number. If you're a glass half empty person, that's 75% of people don't respond to our
Mm-hmm.
best medication.
Mm-hmm.
So then you look at duloxetine. You got to treat 6 to get one better. With gabapentin and Lyrica, you got to treat 8 to get one person 30 to 50% better. Like 8 people. Do you know that means it only works in 11% of patients? That's the number. So pregabalin and gabapentin work in 11% of patients, which basically means 89% of patients don't respond, don't get a 30 to 50% decrease in their pain. So everybody, I see a lot of patients, they come in and they see me and they're like, oh, Dan, something wrong with me. I don't respond to anything. Yeah, no, that's normal. Like you're actually just 100% normal. And it's interesting, if you do the math around, if you work through all those medications, do you know how many people actually respond to that if you've worked through them all? 50%. So half glass full, that's a great outcome. 50% of people will get a 30 to 50% decrease in pain. Half glass empty, 50% have no improvements with working through a ton of medications. And people will have worked through those medications, 4, 6, 8 weeks each medication. You're now 6 months down the track of not having got any better.
Yeah.
That's like, it's really important to realize that's the reality of this. And so, and you can apply that whole understanding to rehab. If we do pain neuroscience and physio, what's the number needed to treat to get one person better? It's somewhere between 3 and 5, depending on which data you want to look at. So once again, that means that it means 20 to 30% of patients respond and the rest don't. So the next question is, and that's where, as a specialist, what I'm seeing is I'm not seeing the ones that responded. I see the ones that didn't. And then I see the ones that we try the medication and they don't respond. What do? We go into an intervention. And what your number needed to treat for intervention is kind of around 2 to 3 for most interventions. So where we're at now, okay, now 50% of those don't respond. Okay, and then we're into then what do you go on to next? And that's sort of like, and so so one of the things about this little soliloquy is it's okay if you don't respond. Like unfortunately, it's really annoying. It's nothing wrong. It's nothing to do with you. It's part of like the whole bag of chronic pain. There's a reason why 20% of the world suffers chronic pain. It's because it's hard to get better.
Yeah, for sure. And for some people, it feels so isolating as well, because they feel like they just must be this like strange individual that no one can help. But the reality is there's 20% of the population are just like you. And I thank you for pointing that out in terms of the medications. It is a little bit sobering and also depressing, though, when you do outline it, but it's the truth and it's the reality. And I appreciate you for sharing it.
I think that the thing that's important that I find good having that understanding, right, is that, you know what, even as a clinician, I want everyone to get better. Like I hate losing. That's like I hate losing. And when I have a patient that's not getting better, I feel bad. Like I know they're in pain, but I feel bad because I haven't been able to help them. Like I hate it. But it's just part of it. It's part of what we've got to do. You've got to look for the options, and then you've got to take, the next, and you go, okay, you haven't responded. This is what is the next thing. And one of the really interesting, I think we were just talking about this before we started, and it's not that the treatment's the wrong treatment. And I think this is the key that where I've come to lately with a lot of my thinking is you've got to find the right patient, or you can find the right treatment for the right patient, but it's then got to be at the right time. So, if you've got lower back pain and that back pain is coming from facet joint arthritis and it hasn't responded to rehab, you know what? You can do a diagnostic block. You can confirm it's facet joint arthritis. We can treat it with some radio frequency. That can decrease the patient's pain. But you know what's the right time to do now? Now it's the right time to go back and do the rehab, because the radio frequency doesn't fix the deconditioning. It doesn't fix the motor patterning. What it does is just denervate the joint and allows you to go back and then do the rehab then. That's when the rehab becomes right time. It's just getting it right treatment, right patient, right time, that's the skill base.
Yeah, for sure. And it seems what you've brought up brings me back to a conversation I had a few weeks back with, well, it was months back now, but it's only released a few weeks, maybe a month or so ago, but with Professor Mark Hutchinson. So they're working on this blood test that's hopefully going to quantify pain, but also tell you what sort of pain type, so we can get more precise with our treatments rather than what now seems to be sadly a little bit of guesswork, and it's kind of like you're trying to hit a home run with a blindfold on. Now that does not undermine your skill and many people's skill in treating this stuff, but man, it would be lovely to have more precision when it comes to pain care. And I think it's just an exciting time that they're working on this. Now obviously it's a huge task, and I wish them all the best. But it's
Yeah,
definitely
no, Mark's
fun.
stuff's amazing, and I think you raise a really good point there, where you're getting more precision, and I think that where we are at the moment, if you look at like how accurate is history, examination, and imaging findings at defining, the cause of pain, you know what? It's really poor. Okay, and particularly if we just put the conversation within the context of lower back pain, if as a clinician you are limited to history examination and imaging findings, your diagnostic accuracy is pretty poor, and as a result, the appropriate diagnosis becomes non-specific lower back pain. Okay,
Mm-hmm.
because you just
Yeah.
not we don't have the skill, like we just don't have the accuracy within those tools to clearly identify the pain. Now,
Yeah.
if you add diagnostic blocks to that, and that's where my skill base comes in. Oh, I can do a diagnostic block. So I can, for me, I think about lower back pain and there's 5 major causes, facets, sacroiliac joints, hips, discs, and nerves. Great. I've I have that additional, I've been gifted with that additional skill base where I can do a diagnostic block and we can see if the pain goes away when you block the nerve supply to the facet, when you block the nerve
Yeah.
supply to the sacroiliac joint, when you block, a hip, or you do some, some nerve blocks. So as a result, you go from non-specific lower back pain to specific lower back pain, which then goes, okay, now I've got some therapeutic options that I can treat this diagnosis with, as opposed to, okay, we've got a diagnosis of non-specific lower back pain. I'm going to apply, which can be one of, 5 major things plus a whole bunch of minor things. Surprise, surprise. Let's say that you've got 2 different patients. They've both got non-specific lower back pain. One of them's actually facet. One of them's actually sacroiliac joint. We add in a third. One of them's actually disc. Treating them the same, surprise, surprise, doesn't work. And so that's where we get these very low number needed to treat, or very high number needed to treat, that only 20% of patients respond. Because, you know what, you're getting it right maybe 20%
Yeah.
of the time.
Yeah. And then some.
So it's and so I'll just finish.
Yeah.
It's important to be able to approach these things in that way, because we have limited, you have limited access to care. You've got limited access to doctors,
Yeah.
so you have to take that sort of approach, but it's not the end in the
Mm,
approach. It's
mm.
recognizing, okay, next step is to go and become more specific about the diagnosis.
Yeah. Yeah, spot on. And yeah, I think nerve blocks have a lot of diagnostic validity, I guess, or effectiveness in terms of helping us to do that. I often am referring for those kind of things with some of the sports docs up here and pain specialists and the like. And I think it's a great way of us getting a bit more diagnostic certainty around what structure is causing or is a part of the pain picture. But sometimes where it's difficult is that sometimes we do find out and we get more diagnostic certainty, and the options to treat are still crap,
Yep.
frankly. and
Yep.
and that's that's where, I'm often coming back to what you term amplifiers, which I think is a great analogy and a way of explaining it. I often coming back to those amplifiers and sort of sorting out some of those things, whether it be stress or poor sleep or their social situation. Pain Coach helps clinicians take the guesswork out of pain relief by tracking pain alongside key lifestyle factors, psychological distress, sleep, nutrition, exercise, and social connection. Pain Coach analyzes this patient data to uncover lifestyle scores, relationships, and trends, helping clinicians guide their patients towards the habits most likely to bring pain relief. If you're a clinician, head to paincoach.online for a free trial. It often, for me, comes back to that, because even when we find a structural problem, the treatment options aren't always great. Now, that doesn't mean I don't think we should treat those things in some circumstances, but sometimes the risk-reward relationship just doesn't really add up for certain interventions. How often are you, in your practice, dealing with some of the amplifiers, and how often are you sort of interventional in your approach?
The answer to both of them is all the time. Okay, it just depends on who the patient is. Okay, so what I'll do with the patient is, so I do a fair bit of pre-consult cheating. Okay, so I get the patient to fill out a DAS-21, so that's a depression, anxiety, and stress score. So that gives me a general indication about how much depression, anxiety, and stress is in the background. I also get them to do what's called a central sensitization inventory. So the central sensitization inventory, surprise, surprise, defines how centrally sensitized they are. Okay, and so what I'll be doing then is the central sensitization inventory splits out into I think it's 5 major categories. So subclinical, so you're pretty much not sensitized. Mild, which is between 30 and 39. Moderate, which is between 40 and 49. Severe, which is between 50 and 59. And extreme, which is over 60. Okay, and so what I'll then be doing is then I will also be asking the patient to draw their pain. Okay, and so I'll be looking for 2 things there. I'll be looking to see. I ask the patient when they draw their pain to scribble over an area when it is when it's an ache or burny type pain. If it's an electric shock, we do a lightning bolt. If it's pins and needles, we do some dots, and if there's numbness, we circle it. Okay, so I start to get a visual understanding of what's happening for their pain. So what I'll do then is I'll take those 3 things. So the perfect patient that comes in that I'm going to go towards an intervention for. So they come in, they have focal pain that's proportional. They've got a central sensitization inventory of like that's mild, like that's subclinical to mild, maybe moderate. They've seen the physio and they've done their rehab, and they've got minimal depression, anxiety, and stress in the background. Okay, so that patient, if you want to go down the track of getting them to meditate and think differently about their pain, that does not work. What you've got to do in that patient is you go, okay, great. This looks like it's going to be a facet, an SIJ, or whatever. You pick your first, what you think your most likely diagnosis is, do a diagnostic block, and away you go. Awesome. Like that is that patient, that's my interventional patient.
Yeah.
So the other type of patient, the next patient that comes in, what do you do? So what they've got is they've got a central sensitization inventory of 75. Everything is wildly amplified. When they draw on their pain diagram, what they do is they color in most of their body or a big wide area, and they've got tons of depression or anxiety or stress in the background. Okay, so that patient, everything is so amplified. If you go down an interventional track on them, I'm telling you now what will take place is that the needle hurts more in them than it does in other people. And so what happens, you do a diagnostic block and they blow up in a big ball of pain afterwards, not because anything's gone wrong, but just because their nervous system is so sensitized. And so that patient, do not do an intervention on that patient. So that's the patient where I'm then going to go, okay, what's driving this sensitization? And so I'll be looking for, okay, you've got a depression, anxiety, and stress score. I'll be then, going through looking at their history for, the things we talked about before, inflammatory disorders, hypothyroidism, diabetes, particularly, we should talk a little bit in a moment about hyperinsulinemia and insulin resistance. And then, your hypermobile patients, your obesity, looking for those things that I can then go, okay, let's go see what amplifiers are taking place. What can I actually turn down and treat? Let's get your amplification under control. I also use in this setting, I do use a reasonable amount of amitriptyline in this setting because amitriptyline is very good at decreasing size and intensity of pain in these patients. And so you look for the amplifiers, you try and decrease the intensity as much as you can. And then you revisit it and then you're like, okay, where are we at now? How big is it? Now it's this big. Okay, great. Now we're down to its, tennis ball, grapefruit size. I can probably go find what's underlying that. And we can then go on and do a diagnostic block at that time. And so, they're obviously the extremes. Most people are in the middle. So you got to, you're hedging your bets sometimes.
Yeah.
But it, for nearly everybody, I'll be doing like a combined approach.
Yeah.
So
yeah,
I don't know if that answers the question, but that's kind of how I think about it.
Yeah. No, I love that. It explains your sort of your reasoning, and I think it's for people listening on. I think it's will be super helpful for them to be able to go, oh, these are kind of my options. This is what's going on, and these are the things that can be contributing. We've covered a lot in 56 minutes or so. I want to end with a question that I ask pretty traditionally on the show, which is if there's someone feeling helpless and despair, that person you basically described at the start of our conversation, helpless, despair, suicidal ideation, what would be your words for them? And I know that's a very challenging question.
Oh, easy. It's not in your head.
Perfect. That wasn't challenging at
It's
all.
easy. Like,
Yeah.
and the amount of times I've said that to patients, and it is innumerable. And the amount of time they then tear up just because someone believes them,
Yeah.
someone recognizes and someone sees them. Like, yeah, like
Yeah.
it's not in your head. You can think about it differently. Sure, you can think about your pain differently. That'll make you better. But no one imagines themselves into a life where you lose everything you love. No one's imagining their pain. It's
Yeah.
real. It's not in your head. Sure, think about it differently, but
Mm-hmm.
you're not imagining it.
You're not making it up. Yeah.
No
What
one's
a,
making it up.
what if they then push back and they say, and I'm pushing a little bit. What if they say, but no one can find what's wrong with me?
Yeah, so then it's back to you know what, you're right. We might not be able to find what's wrong. But that doesn't mean there's nothing wrong. That just means we can't find it. And why we're at a point in time where we may not be able to diagnose something, we may not be able to, like, we can diagnose it, but we can't treat it. You then need to look at other strategies to cope with it better. And those coping strategies are about the way you think, the way you respond, the medications you use, how you do exercise, the diet that you eat, and how you own your pain. That's the stuff. Let's be honest. Pain's hard. You've got to have discipline to get better, and pain takes away your self-efficacy. Discipline's about self-efficacy, and pain takes that away as well. It's hard.
No, I appreciate that. That's great advice to end with. Thank you so much for coming on. I've really appreciated it.
No worries. Pleasure. Thanks for having me.